सो स्टडी विथ मी ब्लॉग्स में आप सभी को स्वागत है। आज हम देखेंगे कार्डिनल मैनिफेस्टेशन एंड प्रेजेंटेशन ऑफ डिजीज में पार्ट 2 में सेक्शन 1 में पेन में आता है और पेन में पैथोफिजियोलॉजी एंड मैनेजमेंट ऑफ पेन आता है। ठीक है, तो यहाँ तक शायद हमने प्रीवियसली यहाँ तक शायद मैंने पढ़ा था, फर्स्ट पेज पढ़ा था। आज सेकंड पेज को ख़त्म करेंगे, 2-3 पेज हारिसन से ये पढ़ रहे हैं। ठीक है, हारिसन इंटरनल मेडिसिन, प्रिंसिपल ऑफ इंटरनल मेडिसिन। तो सेंसिटाइजेशन इज ऑफ अ पर्टिकुलर इम्पोर्टेंस फॉर पेन एंड टेंडरनेस इन डीप टिश्यू। Viscera are normally relatively insensitive to noxious mechanical and thermal stimuli, although hollow viscera do generate significant discomfort when distended. In contrast, when affected by a disease process within an inflammatory component, deep structures such as joint or hollow viscera characteristically become exquisitely sensitive to mechanical stimulation. A large proportion of A delta and C fiber afferent innervating viscera are completely insensitive in normal, non-injured, non-inflamed tissue. That is, they cannot be activated by known mechanical or thermal stimuli and are not spontaneously active. However, in the presence of inflammatory mediator, these afferent become sensitive to mechanical stimuli. Such afferent have been termed as silent nociceptor, and their characteristic properties may explain how, under pathologic condition, the relatively insensitive deep structure can become the source of a severe and debilitating pain and tenderness. Low pH, prostaglandin, leukotriene, and other inflammatory mediators such as BK play a significant role in sensitization. Nociceptor induced inflammation. Primary afferent nociceptor are not simply passive messenger of a threat to tissue injury but also play an active role in tissue protection through a neuroeffector function. Most nociceptor contain polypeptide mediator including substance P, calcitonin gene related peptide CGRP, and cholecystokinin that are released from the peripheral terminal when they are activated. Substance P is an 11 amino acid peptide that is released in peripheral tissue from primary afferent nociceptor and has multiple biologic activities. It is a potent vasodilator, causes mast cell degranulation, is a chemoattractant for leukocytes, and increases the production and release of inflammatory mediators. Interestingly, depletion of substance P from the joint reduce the severity of experimental arthritis. Now, central mechanism. The spinal cord and referred pain. The axon of a primary afferent nociceptor enters the spinal cord via the dorsal root. They terminate in the dorsal horn of the spinal gray matter. The terminal of a primary afferent axon contact spinal neuron that transmit the pain signal to brain sites involved in pain perception. When primary afferent are activated by noxious stimuli, they release neurotransmitter from their terminal that excite the spinal cord neuron. The major neurotransmitter release is glutamate, which rapidly excites the second order dorsal horn neuron. Primary afferent nociceptor terminal also release substance P and CGRP, which produce a slower and longer lasting excitation of the dorsal horn neuron. The axon of each primary afferent contact many spinal neuron, and each spinal neuron receive convergent input from the many primary afferent. The convergence of sensory input to a single spinal pain transmission neuron is of great importance because it underlies the phenomenon of referred pain. All spinal neurons that receive input from the viscera and a deep musculoskeletal structure also receive input from the skin. The convergence patterns are determined by the spinal segment of the dorsal root ganglion that supplies the afferent innervation of a structure. For example, the afferent that supplies the central diaphragm are derived from the third and fourth cervical dorsal root ganglia. Primary afferent with cell bodies in these same ganglia supply the skin of the shoulder and lower neck. Thus, sensory input from both the shoulder, skin, and the central diaphragm converge on pain transmission neuron in the third and fourth cervical spinal segment. Because of this convergence and the fact that the spinal neurons are most often activated by input from the skin, activity evoked in spinal neuron by input from deep structure is often mislocalized by the patient to a bodily location that roughly correspond with the region of skin innervated by the same spinal segment. Thus, inflammation near the central diaphragm is often reported as shoulder discomfort. This spatial displacement of a pain sensation from the site of injury that produce it is known as referred pain. Now, ascending pathway for pain. Most spinal dorsal horn neuron activated by primary afferent nociceptor send their axon to contralateral thalamus. These axons form the contralateral spinothalamic tract, which lies in the anterolateral white matter of the spinal cord. The lateral edge of the medulla and the lateral pons and midbrain. The spinothalamic pathway is crucial for pain sensation in human. Interruption of this pathway produces permanent deficit in pain and temperature discrimination. Spinothalamic tract action ascend to several regions of the thalamus. There is a significant divergence of the pain signal from these thalamic site to several distinct areas of the cerebral cortex that subserve different aspects of the pain experience. Figure 14.4. One of the thalamic projection is to somatosensory cortex. This projection mediates the sensory discriminative aspect of a pain, that is its location, intensity and quality. Other thalamic neurons project to cortical region that are linked to emotional response such as the anterior cingulate and the insular cortex. These pathways to the cortex subserve the affective or unpleasant emotional dimension of a pain. This affective dimension of a pain produces suffering and exerts potent control of behavior. Because of this dimension, fear is a constant companion of a pain. Consequently, injury or surgical lesion to areas of a frontal cortex activated by painful stimuli can diminish the emotional impact of a pain while largely preserving the individual's ability to localize and recognize stimuli as painful. नाउ इसमें ये क्या है, प्राइमरी एक्टिवेशन, ओके, ये बाद में देखेंगे. इवेंट्स लीडिंग टू एक्टिवेशन, सेंसिटाइजेशन एंड स्प्रेड ऑफ सेंसिटाइजेशन ऑफ अ प्राइमरी अफरेंट नोसिसेप्टर टर्मिनल. A. Direct activation by intense pressure and consequent cell damage. Cell damage induces lower pH hydrogen ion and leads to release of a potassium ion and to the synthesis of a prostaglandin and a bradykinin. BK. Prostaglandin increases the sensitivity of a terminal to BK and other pain producing substances. B. Secondary activation. Impulse generated in the stimulated terminal propagate not only to the spinal cord but also into the other terminal branches where they induce the release of a peptide, including substance P SP. Substance P causes vasodilation and neurogenic edema with further accumulation of BK. Substance P also cause the release of histamine H from the mast cell and serotonin 5-HT from the platelets. Okay. Now pain modulation. The pain produced by injuries of a similar magnitude is remarkably variable in different situations and in different individuals. For example, athletes have been known to sustain serious fracture with only minor pain, and Beecher's classic World War II survey revealed that many soldiers in battle were unbothered by injury that would have produced agonizing pain in civilian patients. Furthermore, even suggestion that a treatment will relieve pain can have a significant analgesic effect, that is placebo effect. On the other hand, many patients find even minor injuries such as venipuncture frightening and unbearable, and the expectation of a pain can induce pain even without a noxious stimulus. The suggestion that pain will worsen following administration of an inert substance can increase its perceived intensity, that is nocebo effect. The powerful effect of expectation and other psychological variables on the perceived intensity of pain is explained by brain circuits that modulates the activity of a pain transmission pathway. One of these circuits has linked to hypothalamus, midbrain, medulla, and its selectivity controls spinal dorsal horn pain transmission neuron through a descending pathway. Figure 14.4. Human brain imaging studies have implicated this pain modulating circuit in the pain relieving effect of attention, suggestion, opioid analgesic medication. Figure 14.5. Furthermore, each of the components structure of the pathway contains opioid receptor and is sensitive to the direct application of opioid drugs. In animal, lesion of this pattern of brain activity during placebo analgesia. ओके, यहाँ तक खत्म हुआ. इन एनिमल लेजन ऑफ दिस, this descending modulatory system reduce the analgesic effect of a systematically administered opioid such as morphine. Along with the opioid receptor, the component nuclei of this pain modulating circuit contain endogenous opioid peptides such as enkephalin and beta endorphin. The most reliable way to activate this endogenous opioid mediated modulating system is by suggestion of a pain relief or by intense emotion directed away from the pain causing injury. Example, during severe threat or an athletic competition. In fact, pain relieving endogenous opioids are released following surgical procedure and in patient given a placebo for pain relief. Pain modulating circuit can enhance as well as suppress pain. Both pain inhibiting and pain facilitating neuron in the medulla projects to and control spinal pain transmission neuron. Because pain transmission neuron can be activated by modulatory neuron, it is theoretically possible to generate a pain signal with no peripheral noxious stimuli. In fact, human functional imaging studies have demonstrated increased activity in this circuit during migraine headache. A central circuit that facilitates pain could account for the finding that pain can be induced by suggestion or enhanced by expectation and provides a framework for understanding how psychological factor can contribute to chronic pain. The neuropathic pain. Lesion on the peripheral or central nociceptive pathway typically result in a loss or impairment of a pain sensation. Paradoxically, damage to or dysfunction of this pathway can also produce pain. For example, damage to the peripheral nerve, as occurs in diabetic neuropathy, or to primary afferent, as in herpes zoster infection, can result in pain that is referred to the body region innervated by the damaged nerve. Pain may also be produced by damage to the central nervous system. For example, in some patients following trauma or vascular injury to the spinal cord, brainstem, and thalamic areas that contains central nociceptive pathway. Such pains are termed as neuropathic and are often severe and resistant to standard treatment for pain. Neuropathic pain typically has an unusual burning, tingling, electric shock like quality and may occur spontaneously without any stimulus or be triggered by a very light touch. These features are rare in other type of pain. On examination, a sensory deficit is characteristically coextensive with the area of the patient's pain. Hyperpathia, a greatly exerted exer- exaggerated pain responds to innocuous or mild nociceptive stimuli, especially when applied repeatedly, is also characteristic of a neuropathic pain. Patients often complain that the very lightest moving stimulus evoke exquisite pain, that is allodynia. In this regard, it is of clinical interest that a topical preparation of a 5% lidocaine in patch form is effective for patients with post herpetic neuralgia who have prominent allodynia. A variety of mechanisms contribute to neuropathic pain as with sensitized primary afferent nociceptor, damaged primary afferents including nociceptor become highly sensitive to mechanical stimulation and may generate impulse in the absence of stimulation. Increased sensitivity and spontaneous activity are due in part to an increased density of sodium channel in the damaged nerve fiber. Damaged primary afferent may also develop sensitivity to norepinephrine. Interestingly, spinal cord pain transmission neuron cut off from their normal input may also become spontaneously active. Thus, both central and peripheral nervous system hyperactivity contribute to neuropathic pain. Neuropathic pain cover ହେଇଗଲା. Sympathetically maintained pain. Patient with peripheral nerve injury occasionally develop spontaneous pain in or beyond the region innervated by the nerve. This pain is often described as having a burning quality. The pain typically begins after a delay of hours to days or even weeks and is accompanied by swelling of the extremity, periarticular bone loss, and arthritic changes in the distal joint. Early in the course of the condition, the pain may be relieved by a local anesthetic block the sympathetic innervation to the affected extremity. Damaged primary afferent nociceptor acquire adrenergic sensitivity and can be activated by stimulation of the sympathetic outflow. This constellation of spontaneous pain and sign of sympathetic dysfunction following injury has been termed complex regional pain syndrome. Complex regional pain syndrome, chapter number 19. Okay. When this occur, when this occur after indep- identifiable after an identifiable nerve injury, It is termed as CRPS type 2, also known as post-traumatic neuralgia, or if severe, that is causalgia. When a similar clinical picture appears without obvious nerve injury, it is termed as CRPS type 1, also known as reflex sympathetic dystrophy. CRPS can be produced by a variety of injuries, including fracture of a bone, soft tissue trauma, myocardial infarction, and strokes. CRPS type 1 typically resolves with symptomatic treatment. However, when it persists, detailed examination often reveals evidence of a peripheral nerve injury. Although the pathophysiology of CRPS is poorly understood, the pain and sign of inflammation when acute can be rapidly relieved by blocking the sympathetic nervous system. This implies that the sympathetic activity can activate undamaged nociceptor when inflammation is present. Sign of a sympathetic hyperactivity should be sought in patients with post-traumatic pain and inflammation and no other obvious explanation. Treatment: acute pain. The ideal treatment for any pain is to remove the cause. Thus, while treatment can be initiated immediately, efforts to establish the underlying etiology should always proceed as treatment begins. Sometimes treating the underlying condition does not immediately relieve pain. Furthermore, some conditions are so painful that rapid and effective analgesia is essential. Example: post-operative stage burn, trauma, cancer, sickle cell crisis. Analgesic medication are a first line of a treatment in these cases, and all practitioners should be familiar with their use. Aspirin, acetaminophen, and non-steroidal anti-inflammatory agents. NSAID. These drugs are considered together because they are used for similar problems and may have a similar mechanism of action. Table 14.1. All these compounds inhibit cyclooxygenase, COX, and except for acetaminophen. All have anti-inflammatory action, especially at higher dosage. They are particularly effective for mild to moderate headache and for pain of a musculoskeletal origin. Because these are effective for this common type of pain and are available without prescription, COX inhibitors are by far the most used analgesic. They are absorbed well from the gastrointestinal tract with occasionally use, have many minimal side effects. With chronic use, gastric irritation is a common side effect of aspirin and NSAID, and is the problem that most frequently limits the dose that can be given. Gastric irritation is most severe with aspirin, which may cause erosion and ulceration of the gastric mucosa, leading to bleeding or perforation. Because aspirin irreversibly acetylates platelet COX and thereby interfere with coagulation of blood. Gastrointestinal bleeding is a particular risk. Older age and history of a gastrointestinal disease increase the risk of aspirin and NSAID. In addition to a well-known gastrointestinal toxicity of NSAID, nephrotoxicity is a significant problem for patients using this drug on a chronic basis. Patients at risk for renal insufficiency, particularly those with significant contraction of their intravascular volume, as occurs with chronic diuretics use or acute hypovolemia, should avoid NSAID. NSAID can also increase blood pressure in some individuals, Long-term treatment with NSAID require regular blood pressure monitoring and treatment if necessary. Although toxic to liver when taken in high dose, acetaminophen rarely produces gastric irritation and does not interfere with platelet function. The introduction of a parenteral form of NSAID, that is ketorolac and diclofenac, extend the usefulness of this class of compound in the management of acute severe pain. Both agents are sufficiently potent and rapid in onset to supplant opioids as first line treatment for many patients with acute severe headache or musculoskeletal pain. There are two major classes of COX. COX-1 is constitutively expressed and COX-2 is induced in the inflammatory state. Now, drug for relief of a pain, non-narcotic analgesic, usual dose interval, generic name dose mg, interval comments. Acetyl salicylic acid, acetyl salicylic acid 650 mg per oral, interval every 4 hour ନେଇପାରିବ, enteri coated preparation available. एसिटामिनोफेन 650 mg पर ओरल एवरी 4 घंटे में ले सकते हो, साइड इफेक्ट अननोन है। ओके, आइबुप्रोफेन 400 mg पर ओरल एवरी 4 से 6 घंटे अवेलेबल विदाउट प्रिस्क्रिप्शन। नाप्रोक्सेन 250 से लेकर के 500 mg पर ओरल एवरी 12 घंटे। नाप्रोक्सेन इज द कॉमन NSAIDs that possesses the least cardiovascular risk but it has a somewhat higher incidence of gastrointestinal bleeding. Then फेनोप्रोफेन 200 mg पर ओरल एवरी 4 से 6 घंटे ले सकते हो, कॉन्ट्राइंडिकेटेड इन रेनल डिजीज। इंडोमेथासिन 25 से लेकर के 50 mg पर ओरल एवरी 8 घंटे में ले सकते हो, गैस्ट्रोइंटेस्टिनल साइड इफेक्ट कॉमन होता है। कीटोरलैक 50 से लेकर के 60 IM IV दे सकते हो, एवरी 4 से 6 घंटे में दे सकते हो, अवेलेबल फॉर पैरेंटरल यूज। सेलिकोक्सिब 100 से लेकर के 200 पर ओरल दे सकते हो, एवरी 12 से लेकर के 24 घंटे में, यूजफुल फॉर आर्थराइटिस पेन। ओके, सेलिकोक्सिब। भाल्डिकोक्सिब 10 से लेकर के 20 mg पर ओरल एवरी 12 घंटे या 24 घंटे में दे सकते हो, रिमूव्ड फ्रॉम US मार्केट इन 2005। जेनेरिक नेम पैरेंटरल डोज पर ओरल डोज mg कमेंट्स। नार्कोटिक एनाल्जेसिक यूजुअल डोज एंड इंटरवल, कोडिन 30 से लेकर के 40 mg एवरी 4 आवर एंड ये पैरेंटरल डोज एंड पर ओरल डोज आपका हो जाएगा 30 से लेकर के 60 mg एवरी 4 घंटे में। नोजिया आपका कॉमन रहेगा। ऑक्सीकोडन यहाँ पर ये आई थिंक ये सेम है, 30 से लेकर के 60 आई थिंक। ओके, थोड़ा देख लेते हैं। नोसिया ऑक्सीकोडन है, ऑक्सीकोडन ऑक्सीकोडन ओके, पेन मैनेजमेंट करने के लिए ऑक्सीकोडन का जो डोज होगा ओरल इमीडिएट रिलीज में, इनिशियल डोज 5 से लेकर के 10 mg एवरी 4 to 6 आवर आज नीडेड। ठीक है, तो ऑक्सीकोडन पता चल गया। पैरेंटरल ओके, 5 से लेकर के 10 एवरी 4 से लेकर के 6 घंटे में। अच्छा, ये IV रूट में शायद ये नहीं है। ओरल रूट की बात यहाँ पर हो रहा है। ओपोइड नाइफ पेशेंट में इनिशियल डोज 1 से लेकर के 10 mg एडमिनिस्टर ओवर 1 to 2 मिनट एट इंटरवल ग्रेटर देन 4 आवर बिटवीन डोजेस। IV continuous infusion initial 2 mg/hour. Okay. ऑक्सीकोडोन हो गया। तो पर ओरल डोज 5 से लेकर के 10 एवरी 4 to 6 आवर यूजुअली अवेलेबल हुई थी एसिटामिनोफेन एंड एस्प्रिन। ठीक है। ऑक्सीकोडोन एक्सटेंडेड रिलीज पैरेंटरल डोज यहाँ पर मेंशन नहीं है, बट पर ओरल रूट में 10 से लेकर के 40 mg एवरी 12 आवर ओरल एक्सटेंडेड रिलीज टैबलेट आता है। हाई पोटेंशियल फॉर मिस यूज। यह हाईली पोटेंट ड्रग होता है। ओके, हाई पोटेंशियल फॉर मिस यूज। अच्छा, मिस यूज करने की ये ज़्यादा संभावना है इसमें, नारकोटिक है। अच्छा, मॉर्फिन। मॉर्फिन पेरेंट्रल डोज 5 mg आप दे सकते हो एवरी 4 घंटे में। ओरल रूट में 30 mg एवरी 4 आवर में दे सकते हो। कमेंट कुछ नहीं है। मॉर्फिन सस्टेंड रिलीज आपका यहाँ पर कुछ मेंशन नहीं है। ओरल रूट में 15 से लेकर के 60 mg BID से लेकर के TID दे सकते हो। ओरल फॉर्मुलेशन अगर दोगे स्लो रिलीज प्रिपरेशन। ओरल फॉर्म में स्लो रिलीज प्रिपरेशन मतलब एक्सटेंडेड रिलीज। हाइड्रोमॉर्फोन वो पेरेंट्रल में 1 से लेकर के 2 एवरी 4 आवर एंड यहाँ पर 2 से लेकर के 4 mg एवरी 4 आवर। शॉर्टर एक्टिंग देन मॉर्फिन सल्फेट। ओके। देन लेवोफानल, ये 2 mg दे सकते हो एवरी 6 से लेकर के 8 आवर एंड ओरल में 4 mg एवरी 6 से लेकर के 8 आवर। लॉन्गर एक्टिंग देन मॉर्फिन सल्फेट, ऑब्जर्व वेल पर ओरल। ओके। देन आपका भाई ये कब तक खत्म होगा? देन आपका आ जाता है मेथाडोन। मेथाडोन जो होता है वो पेरेंट्रली आपको देना पड़ेगा 5 से लेकर के 10 mg एवरी 6 से लेकर के 8 घंटे। ये भी 5 से लेकर के 20 mg एवरी 6 से लेकर के 8 घंटे। ड्यू टू लॉन्ग हाफ लाइफ रेस्पिरेटरी डिप्रेशन एंड सिडेशन में परसिस्ट आफ्टर एनाल्जेसिक इफेक्ट सबसाइड। थेरापी शुड नॉट बी इनिशिएटेड विथ लेस than 40 mg per day and dose escalation should be made no more frequent than every 3 days. मेपेरिडिन 50 से लेकर के 100 एवरी 3 से लेकर के 4 आवर 300 mg एवरी 4 आवर। पुअरली ऑब्जर्व पर ओरल नॉर मेपेरिडिन इज टॉक्सिक मेटाबोलाइट। Routine use of this agent is not recommended. Then butorphanol पेरेंट्रल नहीं है। डाटा 1 से लेकर के 2 mg एवरी 4 आवर इंट्रानाजल स्प्रे। ब्यूटोरफानल। देन फेंटानिल 25 से लेकर के 100 माइक्रोग्राम पर आवर दे सकते हो। ओरल रूट में डाटा नहीं है। 72 आवर ट्रांसडर्मल पैच। ब्यूप्रीनॉर्फिन 5 से लेकर के 20 मिली माइक्रोग्राम पर आवर। ओरल रूट में डाटा मेंशन नहीं है। 7 डे ट्रांसडर्मल पैच। देन ब्यूप्रीनॉर्फिन 0.33 mg एवरी 6 से लेकर के 8 पैरेंट्रल एडमिनिस्ट्रेशन करना पड़ेगा। ट्रामाडोल आईवी रूट मेंशन नहीं। 50 से लेकर के 100 एवरी 4 to 6 आवर। मिक्स्ड ओपॉइड एड्रेनर्जिक एक्शन, मिक्स्ड ओपॉइड एड्रेनर्जिक एक्शन, ट्रामाडोल। मिक्स्ड ओपॉइड देव एड्रेनर्जिक एक्शन करिवो, ठीक है। ओके। जेनेरिक नेम ऑप्टेक ब्लॉकेड, 5-HT नॉरएपिनेफ्रिन, sedative potency, anticholinergic potency, then orthostatic hypotension, cardiac arrhythmia, एवरेज डोज मिलीग्राम पर डे, रेंज आपका mg पर डे कितना हो जाएगा। डोक्सेपिन 5-HT अगर देखेंगे ऑप्टिक ब्लॉकेड 2 पॉजिटिव है, नॉरएपिनेफ्रिन में 1 पॉजिटिव है। यहाँ पर क्या मेंशन है? सिडेटिव पोटेंसी डोक्सेपिन का आपका हाई होता है। एंटीकोलिनर्जिक पोटेंसी मॉडरेट आएगा। ऑर्थोस्टैटिक हाइपोटेंशन मॉडरेट। कार्डियक अराइथमिया लेस। एवरेज डोज दे सकते हो 200 mg पर डे दे सकते हो। रेंज आपका 75 से लेकर के 400 मिलीग्राम। एमिट्रिप्टिलिन 5-HT में 4+ है। नॉरएपिनेफ्रिन ये 2+ है। ये प्लस का क्या चक्कर है? अच्छा, सिडेटिव पोटेंसी एंटी अमीट्रिप्टिलिन में हाई रहेगा। एंटीकोलिनर्जिक पोटेंसी आपका हाईएस्ट भी रहेगा। ऑर्थोस्टैटिक हाइपोटेंशन मॉडरेट करेगा। कार्डियक अराइथमिया इसमें ज़्यादा चांसेस है ये से। एवरेज डोज आपका 150 mg पर डे दे सकते हो। रेंज आपका 25 से लेकर के 300 mg पर डे। देन इमिप्रामिन 5-HT में आई थिंक ये अट्रैक्टिव पावर है। इमिप्रामिन 4 पॉजिटिव, नॉरएपिनेफ्रिन में 2। सिडेटिव पोटेंसी आपका मॉडरेट ही आएगा। एंटीकोलिनर्जिक पोटेंसी मॉडरेट आएगा। ऑर्थोस्टैटिक हाइपोटेंशन ज़्यादा है, हाई। कार्डियक अराइथमिया, यस कार्डियक अराइथमिया होगा इससे। इमिप्रामिन एवरेज डोज आपका रह जाएगा कितना? 200 mg पर डे एंड 75 से लेकर के 400 आपका हो जाएगा। देन आपका नॉरट्रिप्टिलिन 5-HT में 3 पॉजिटिव, नॉरएपिनेफ्रिन में 2 पॉजिटिव। सिडेटिव पोटेंसी मॉडरेट, एंटीकोलिनर्जिक पोटेंसी ये भी मॉडरेट। ऑर्थोस्टैटिक हाइपोटेंशन ये आपका क्या हो जाएगा? लो है। कार्डियक अराइथमिया यस। एवरेज डोज आपका 100, रेंज आपका 40 से लेकर के 150। देन डेसिप्रामाइन 5-HT में 3 पॉजिटिव, नॉरएपिनेफ्रिन में 4 पॉजिटिव। सिडेटिव पोटेंसी आपका लो आएगा। डेसिप्रामिन एंटीकोलिनर्जिक पोटेंसी लो आएगा। ऑर्थोस्टैटिक हाइपोटेंशन लो आएगा। कार्डियक अराइथमिया यस। एवरेज डोज आपका 150, रेंज आपका 50 से लेकर के 300 mg। देन वेनलाफैक्सिन ये 5-HT में 3 पॉजिटिव, नॉरएपिनेफ्रिन में 2 पॉजिटिव। सिडेटिव पोटेंसी लो आएगा। एंटीकोलिनर्जिक परसेंट इसमें नहीं है। ऑर्थोस्टैटिक हाइपोटेंशन नो। कार्डियक अराइथमिया नो। एंड डोज आपका एवरेज डोज 150 mg पर डे दे सकते हो। रेंज आपका 75 से लेकर के 400 mg पर डे। देन डुलोक्जेटाइन 5-HT में 3 पॉजिटिव, नॉरएपिनेफ्रिन 3 पॉजिटिव। सीडेटिव पोटेंसी आपका लो आएगा, एंटीकोलिनर्जिक पोटेंसी नॉन है, ऑर्थोस्टैटिक हाइपोटेंशन नॉन, कार्डियक अराइथमिया नो। एवरेज डोज आपका 40 mg पर डे आएगा, रेंज होगा 30 से लेकर के 60। देन जेनेरिक नेम एंटी कन्वल्सेंट एंड एंटी अराइथमिक। कार्बामाजेपिन आपका पर ओरल डोज हो जाएगा 200 से लेकर के 300, इंटरवल एवरी 6 आवर में दे सकते हो। रेयर अप्लेस्टिक एनीमिया होगा, जीआई इरिटेशन होगा, हेपाटोटॉक्सिसिटी रहेगा। ऑक्स कार्बामाजेपिन आपका 300 mg, ये आपको बीआईडी देना है, तो 600 mg आपका हो जाएगा, सिमिलर टू कार्बामाजेपिन। गाबापेंटिन बी, ये क्या होता है? तो 600 से लेकर के 1200 mg आप दे सकते हो, इंटरवल एवरी 8 आवर। ये डिजीनेस करेगा, जीआई इरिटेशन करेगा, यूजफुल इन ट्राई जेमिनल न्यूरल्जिया। देन आपका प्रेगावालिन 150 से लेकर के वो 600, इंटरवल बीआईडी, सिमिलर टू गाबापेंटिन, ड्राई माउथ, इडिमा आपको करेगा। एंटी डिप्रेशन, एंटी कन्वल्सन, एंटी अराइथमिक have not been approved by the US Food Drug Administration for the treatment of a pain. Gabapentin B in doses up to 1800 mg per day is FDA approved for post-herpetic neuralgia, GI gastrointestinal, 5-HT serotonin, any norepinephrine, NSAID होची non-steroidal anti-inflammatory agent। ऑल करेक्ट, ओके। तो आज यहाँ हमने फिनिश किया है, इसको मेंशन कर देते हैं। रीडिंग, आज का डेट क्या है? 24 दिसंबर 24/12/25। टाइमिंग हो गया 1:33 PM, सॉरी AM नाइट। सो आज के स्टडी विथ मी ब्लॉग्स में इतना ही, फिर मिलते हैं एक और स्टडी विथ मी।